Hello, everyone. We're here doing another podcast, and today I'm very excited to have one of my favorite radiation oncologists, Dr. Tugce Kutuk, telling us a little bit about a device that I saw a paper that she wrote on called GammaTile. Tugce, can you introduce yourself to everyone?
Oh, thank you, Dr. Lally. It's a pleasure to be here on the ACRO podcast as a radiation oncology resident. To share a bit about my background, I completed my medical degree and radiation oncology residency at one of the most prestigious institutions in Turkey. So during my time in Turkey, I focused on both clinical and research and also involved in a couple of projects in International Atomic Energy Agency aimed to improve radiation oncology services in low and middle income countries. After my residency, I joined Miami Cancer Institute, where I had a highly productive period. So the collaborative environment at Miami Cancer Institute allowed me to dive deeply into translational and clinical research, particularly in brain metastasis. Currently, I am at the Ohio State University, continuing my US residency and research in radiation oncology. And I'm also involved with the Radiosurgery Society, working the residence committee. So that's all about me.
Tell me something before we get into the published data. For those who are listening to this and don't really know what GammaTile is, can you explain it to the audience for us?
Sure. So GammaTile, or also we can say surgically targeted radiation therapy, is an FDA-cleared modality designed for the treatment of brain tumors. So the device consists of small, biocompatible, resorbable tiles, approximately 2 by 2 centimeter and 4 millimeter thick, containing cesium-131 seeds. So these seeds are embedded within a collagen matrix, which acts as a spacer and creating a 3 millimeter buffer between the seeds and surrounding brain tissue. Moreover, the matrix stabilizes the seeds, ensuring no migration occurs, which maintain predictable dosimetry for us. This design ensures that the radiation dose delivered directly to the high risk margins where recurrence is most likely. So cesium 131 allows for rapid dose delivery at the tumor bed, providing a total dose of approximately 120, 150 gray at the cavity surface and 60, 80 gray at the 5 millimeter depth, significantly higher than the typical doses achieved with external beam radiation therapy. This high dose radiation over a short duration is particularly beneficial in managing rapidly proliferating tumor cells in CNS. So overall, GammaTile presents a novel, efficient, and localized method of radiation delivery, offering precise dosimetry, immediate onset of action, and minimal risk to healthy brain tissue. And I guess making it a valuable option in the treatment of brain tumors.
Yeah, in my institution, we're using it and we're one of their centers of excellence. I mean, it's really impressive about how it can deliver more dose to the tumor bed and things like that for the patient. Um, Before we get going too far into this, I know GammaTile was developed with cesium, and before that, we were using more iodine 125. Can you give me a little bit of a history of the isotopes and how we have evolved with GammaTile into using more of cesium 131?
So sure, before cesium-131 became widely adopted in brachytherapy for brain tumors, the approach was the use of iodine-125. So iodine-125 has a half-life of about 59.4 days. So for a while, it offered some promising advantages in treating brain tumors. However, several challenges began to emerge with its use, particularly related to dynamics of the resection cavity. So, as the resection cavity naturally shrinks after tumor removal, the fixed iodine 125 seeds can end up closer to the surrounding healthy brain tissue. So this proximity led to an increased risk of hotspots. As a result, rates of radiation necrosis increased to as high as 23% in literature. To mitigate this risk, clinicians started to exploring alternatives, which is when cesium-131 started gaining attention with a much shorter half-life, half-life of about 9.7 days, presented a better solution for addressing the issues with iodine-125. So the shorter half-life allowed to deliver therapeutic radiation much faster, which reduced risk of complications like radiation necrosis, because by the time the resection cavity shrank, most of the radiation dose had already been delivered. So this meant fewer side effects and a faster treatment completion, allowing patients to begin adjuvant therapies such as chemo or immunotherapy sooner. So another key improvement with cesium-131 is its ability to offer more uniform and precise dosing to clinical target volume compared to iodine-125. In fact, several studies in literature comparing these two modalities have shown that cesium-131 offers significant dosimetric advantages. So overall, the transition from iodine-125 to cesium-131 marks as a significant leap forward in intracavitary brachytherapy in brain tumors. We can say that cesium-131 has more favorable half-life, superior dosimetry, and superior safety profile have made it a better option for treating brain metastases and other challenging brain tumors.
Yeah, it just brought me back to some flashbacks when I was taking my boards and had to remember all the half-lives and everything. What's funny is also as I've been older, getting older now, a little more grayer too. I remember when we used to put the iodine seeds in. And I remember when they were doing gliosite and putting in that balloon into the cavity. And when I've seen this done at my practice by one of my partners, the dosimetry has, really impressed me a lot. Can you explain how this innovative approach to brain brachytherapy is different from what they've done in the past?
Sure. So brain brachytherapy may provide a safer alternative to ray radiation. So prior brachytherapy methods have varied considerably across institutions and were limited due to the need to directly place the seeds into tissue. So these techniques resulted in direct brain contact with radioactive sources and was often inconsistent in terms of spacing between seeds, leading to suboptimal dosimetry and longer surgery times, which means resulting in increased staph exposure and the potential for the seeds to move after placement, which ultimately limited adoption of the brachytherapy into our clinical practice. So one of the key benefits of this innovative form of brain brachytherapy is faster radiation delivery, as I mentioned previously. So cesium-131 has a much shorter half-life, meaning the bulk of the radiation is delivered within first few weeks after placement. It means it starts working immediately on any residual tumor cells in cavity, minimizing the chance of a tumor regrowth in postoperative period. Another major benefit of GammaTile, which embeds the seeds into a resorbable collagen matrix. The placement takes only a few minutes, adding a minimal time to overall surgery. So this eliminates the waiting period that typically occurs with traditional EBRT techniques, where patient often needs to recover before starting treatment. And additionally, I mentioned before, GammaTile has significantly reduced the issue of seed migration. So lastly, I want to mention that one of the most important clinical benefit is the reduced risk of radiation necrosis. So clinical studies have shown that cesium-131 has much lower rates of radiation necrosis, often below than 5% in literature. So, but while still achieving excellent tumor control. In our case series with 12 brain metastases in recurrent setting, which was published about 2 years ago in Brachytherapy Journal, there was only one instance of symptomatic grade 2 radiation necrosis 7 months after GammaTile placement, but the patient had multiple treatment course before GammaTile, like 2 courses of SRS and 2 surgeries. So in summary, this new form of brain brachytherapy often offers like a faster, more effective radiation delivery, easier application during surgery, better stability of the seeds with collagen matrix, and significantly improve safety for patients due to reduced risk of radiation necrosis.
Yeah, it's like the brachytherapy now kind of understands its role and its relationship to merge with surgery. I kind of remember when I was a trainee, I used to irradiate mice and some cells using a cesium-137 irradiator. And, that was probably more than 20 years ago now. And I bet you that, cesium irradiator is still there now. You know, can you explain to me a little bit about how, with this newer version of cesium and a shorter half-life, how it gives GammaTile certain advantages?
So I mentioned that GammaTile one of the key advantages of GammaTile is short half-life, which is around 9.7 days. This means that within that time frame, 50% of the radiation dose already delivered. By 6 weeks, about 95% of the intended dose is given. The benefit of this is the radiation is delivered in relatively short period, allowing it to target the tumor effectively while minimizing prolonged exposure to surrounding healthy brain tissue due to postoperative cavity dynamics after surgery.
That's really interesting about the half-life and everything and how you're able to optimize it. But, when you're delivering these little, seeds within their collagen matrix and everything, how do you optimize the dosimetry for the GammaTile placement?
Well, GammaTile optimizes dosimetry through several key design features. So first, GammaTile uses a collagen matrix that serves as a protective barrier, spacing the cesium-131 seeds at precise distances. So this collagen matrix has a dual role. It prevents direct radiation contact with healthy tissue that maintains the shape of the implant for approximately 4 half-lives of the seeds. By stabilizing the geometry, it ensures there are no radiation hotspots in our target tissue, which helps avoid uneven dose distributions. So also, this prevents the seeds from migrating, unlike other brain brachytherapy methods. Additionally, it's a brachytherapy, allows the radiation dose to drop off very rapidly. This rapid dose fall-off minimizing the radiation exposure to surrounding structure, which is crucial in protecting critical areas in brain.
All right, that's great to hear. Now that we have some background about GammaTile, can you tell me a little bit about your research and what it was that got you interested in comparing GammaTile with other types of radiation modalities that we currently use in patients with brain tumors?
Firstly, I want to give like a little bit background of brachytherapy. So brachytherapy has several benefits over EBRT when used as a salvage therapy in brain tumors. First, resection allows for pathological assessment to differentiate radiation necrosis from tumor progression, as well as removing of the causative process, which results in symptomatic relief in patients. Second, brachytherapy allows for radiotherapy to be delivered directly into the surgical cavity, which limits radiation exposure to surrounding brain. Third, it is delivered immediately after resection, as opposed to traditional EBRT, which is typically delayed 3-4 weeks after surgery, is associated with an increased risk of recurrence in patients. Also, as the patient is treated at the time of surgery, there is no concern that the patient may be lost to follow-up. Perhaps the most concerning, nearly 20% of patients never receive the recommended EBRT postoperatively, which increases risk of recurrence. So these challenges are further magnified in the setting of recurrent setting. Controlling larger postoperative cavities with stereotactic radiotherapy becomes increasingly difficult, and the risk of radiation necrosis grows substantially, limiting the radiation options with the EBRT. So this situation can leave patients with suboptimal local control and fewer therapeutic choices with EBRT. So brachytherapy, and specifically GammaTile, present an alternative in these recurrent scenarios. I mentioned about dosimetric advantages of GammaTile previously. So our research was driven by the need to explore these dosimetric advantages in compared to modern EBRT modalities, particularly in recurrent brain cases where conventional EBRT might underperform in terms of disease control and safety. Through this study, we aim to compare the biological effective doses of GammaTile with other EBRT techniques to determine which modality offers the best balance between efficacy and minimizing radiation toxicity, especially in recurrent brain metastasis.
That's good to hear. I mean, that's really exciting. The idea of starting applying dose right away instead of waiting 3 to 4 weeks when you do with external beam, I think is a great benefit to the patient in this disease. In your research, how did you capture the comparison of GammaTile to the other modalities?
For our research, we reviewed patients with recurrent brain metastasis who underwent treatment using GammaTile implants in our center. So it was 12 resection cavities where we prescribed a dose of 60 gray at a depth of 5 millimeters from the surgical bed. So let me explain the GammaTile procedure briefly. Once the tumor was removed, we implanted GammaTile directly into the resection cavity. So the number of tiles used depended on preoperative MRI images, and the goal was to cover the entire resection cavity without a gap, ensuring a precise fit, especially in cases where the cavity shape was irregular. So post-implantation, patients had CT and MRI scans within 24 hours, and we use a specialized software to perform post-implant dosimetry to ensure accurate seat placement and dose distribution. So this data allowed us to map out the radiation dose to both the tumor sites and the surrounding brain tissue. So how did we actually compare GammaTile to other modalities like CyberKnife, Gamma Knife, and intensity modulated proton therapy? This is where biologically effective dose became critical. So BED helped us compare different radiation treatment techniques that deliver their doses at varying rates and energies. So we replant the same patients using CyberKnife, Gamma Knife, and IMPT, applying their respective clinical protocol in our center. For our study, we calculated BED for each modality to directly compare the impact on both the tumor and normal tissues. For GammaTile, we accounted for factors like half-life of the cesium, the tumor cells repair rate, tumor doubling time. We then calculated BED for CyberKnife, GammaKnife, and IMPT based on their fractionation schedule. We also looked at the dose to surrounding brain to assess the risk of radiation necrosis. We measured key parameters such as the minimum dose covering 90% and 95% of the resection cavity, and also evaluated those to normal brain tissue. To sum it up, we captured this comparison by translating all radiation dose into a common language BED, allowing us to directly compare the dosimetry of GammaTile with other EBRT techniques.
So within your study, I think you had like 12 recurrent brain mets, okay? When you did the study comparing GammaTile's BED to those other, radiosurgery or proton therapy, what did you find? How'd you do it?
So the results were quite interesting. So for tumor cavities with no margin, the median BED in 10 gray, 90% and 95% values for GammaTile were significantly higher compared to CyberKnife, GammaKnife, and IMPT. So this difference was highlighting GammaTile's superior dosimetry in delivering a higher dose to target. However, when we checked the scenario with a 5 millimeter margin to resection cavity, the median BED in 10 gray, 90% and 95% for GammaTile was significantly lower as compared to CyberKnife and IMPT, though it was not significant different from GammaKnife. So this indicates that while GammaTile excels in providing high BED for tumor cavities, the dose fall-off is better compared to CyberKnife and IMPT. Interestingly, the median V24 in 3 gray, which indicates risk of radiation necrosis, was higher across all EBRT modalities when compared to GammaTile. So this can demonstrate that GammaTile not only delivers higher doses to tumor, but also reduces exposure to surrounding healthy brain tissues, potentially lowering the risk of radiation necrosis. In summary, our sample size were small, but our study indicates that GammaTile show promise as an effective treatment for irradiating post-surgical cavities. So it achieves higher target BED doses while maintaining lower exposure to normal brain tissue compared to other EBRT modalities like CyberKnife, GammaKnife, and IMPT. This may lead to better clinical outcomes with a potentially reduced risk of radiation necrosis, making it a good option in evolving landscape of radiation oncology of CNS treatment.
Good. In this study, what surprised you?
So, one insight that truly surprised me was the remarkable precision GammaTile achieved in minimizing radiation exposure to surrounding tissue while delivering an effective dose directly into the tumor cavity. So while we expected GammaTile's localized dosimetry to offer some advantage, its ability to maintain optimal coverage with such a sharp dose follow-up was striking, especially in comparison to CyberKnife and IMPT. Furthermore, the rate of radiation necrosis remained low, even with such a high cumulative doses, reinforcing GammaTile's potential as a safe radiation option for challenging recurrent cases. We also observed very high local control rates in patients with recurrent brain metastasis, which supports GammaTile as an effective treatment modalities in these complex clinical scenarios.
So tell me, what would you say is the optimal local control that we should be looking for here with GammaTile? Define that for me. Tell me about it.
So in our study, we published in 2023 in Brachytherapy, we investigated local control outcomes using GammaTile as a salvage therapy in 12 brain metastases. All of them recurred after prior treatment with SRS and/or whole brain radiation therapy. So these were challenging cases as many of the lesions had been previously treated with aggressive radiotherapy modalities. So when we checked the dosimetry results of GammaTile, the median BED in 10 gray was 132 gray for 90% isodose line and 116 gray in 95% isodose line. Impressively, the median maximum point dose for the target reached about 1000 gray, providing an aggressive dose to control these recurrent tumors. So at the median follow-up of 15 months, maximum follow-up was 29 months. No local recurrences were detected in our patient group, resulting in a remarkable 100% local control rate. So this was a striking result compared to local control rates of previous first-line EBRT treatments, where the 6-month control was 66%, 1 year was 33%, and I think 1.5 year was around 25%. So in contrast, the GammaTile achieved 100 local control across all these time points, representing a significant improvement in same patient population. So overall, the study highlights the efficacy of GammaTile in achieving high local control rates, particularly in complex recurrent cases where previous radiation therapy options had failed to prevent tumor recurrences.
So tell me, great job, but is there any other key findings or conclusions you want to share?
So one of the key findings from our study was the enhanced precision that GammaTile offers in targeting tumor cavities. And this precision is primarily due to unique design of the GammaTile implants. So another aspect is the potential for reduced treatment times and improved patient convenience. And unlike traditional EBRT, which often require multiple sessions, multiple fractions, and GammaTile can be implanted during the time of surgery. This benefits patient experience. And from our experience using GammaTile, I found it to be an effective and innovative approach for treating brain tumors. The technology allows for a personalized treatment strategy tailored to the unique anatomy of each patient, which is critical in our radiation oncology practice. Additionally, the reduced risk of radiation exposure to healthy brain tissue is a significant advantage, particularly in a patient population that often present with complex treatment histories and comorbidities. While further research with larger patient cohorts is needed to validate these findings, our initial results suggest that GammaTile could be an integral part of the treatment landscape for brain tumors, improving outcomes and enhancing the quality of care for the patients. I think this technology represents an exciting advancement in the field of radiation oncology, and I look forward to seeing how it evolves in clinical practice with the new studies.
Yeah, it excites me too. After years of the frustration with the prior brachytherapy, I find this exciting and unique opportunities to do some things. And I'm just kind of curious, from what you know and your perspective, primary brain tumors, brain mets, any difference with how the technology is applied or utilized?
So I personally, I don't have any experience with primary brain tumors in the first line setting or the recurrent setting, but I know that there are some clinical trials are going on for the primary brain tumors with GammaTile. So the high dose to the cavity might be an advantage to control the remaining primary brain tumor cells because it's like most commonly in around the surgical cavity. From my perspective, it can be a good option also for the primary brain tumors, probably in the recurrent settings, but might be an option for primary settings with combination with EBRT methods too.
That's interesting. Hey, I gotta say, I really appreciate you taking the time to talk with me today. It's been a pleasure and an honor, and I hope to see you in Vegas at the ACRO annual meeting. You gonna be there?
Yes, currently I am prepared. I'm working on a couple of abstracts. I'm gonna submit them before the deadline, and I'm so excited for Vegas ACRO meeting.
See you then.
See you.